Okay, so hello, I am Allison Cowan. I'm a psychiatrist at Wright State University, as this slide clearly shows. I'm one of the psychiatrists for Ohio's telepsychiatry project for intellectual and developmental disabilities. Today, I will be talking about psychotic disorders in folks with IDD. If you were here with us last week, this will be a review for you, but if you weren't here, I just want to let you know about what we do a little bit. So here's our a little bit about our Ohio's telepsychiatry project for intellectual disability. We started doing this in 2012. So we are familiar with providing psychiatric services to people all over the state with our psychiatrists and our psychiatry residents and our fellows. And we have medical students rotate with us too. We serve 86 of Ohio's 88 counties, and we have over 2,000 patients. We're very proud of the work we do. Let me go over my disclosures too. So I don't have any conflicts of interest. I don't have any industry or pharmaceutical sponsorship. We do receive grant funding from the Ohio Department of Mental Health and Addiction Services. We receive grant funding from Ohio's Department of Developmental Disabilities. And then, as I told you about, we have our telepsychiatry project for intellectual disability. And then all of the cases I will talk about today are de-identified. They're composites. They are fabricated, and they may contain like components that are familiar to you, but a lot of psychotic symptoms are similar among folks. So there's no one single person described. So if you are a person who worries about that, do not worry about it. Oh, and then also here, let me see. Can you all type into the chat? Can maybe somebody just say hi? And then can other people type to see if you see that other person say hi? So if somebody could like get the keyboard out and just be like, hello, how are you? What is going on today? That would be great. That lets me know how we can participate better in this webinar. Okay, anybody, literally one person. Let's see, if your name is Rob, I don't know, or Amy, go ahead and just type hi into the chat. I just picked those names out of.
We've got a bunch coming in. Actually, let me switch something real quick and you should be able to see those. No worries, that's no problem, that's my fault.
That's so funny. Okay. Okay, so we're gonna let Megan work on that, and then I will just keep going, and then I bet it'll be figured out by the time we get there. All right, so what we are doing today is I'm gonna go ahead and list the adaptations for the diagnoses of these psychotic disorders in folks with IDD. We have, you know what, I'm just gonna grab it. We have this, so I think we all probably know the DSM-5 TR. So the DSM ID2 takes DSM-5. They haven't made the DSM-5 TR adaptation yet. But if you're curious, if you work with people who have intellectual and developmental disabilities, go ahead and pick this up. It's really helpful. It walks you through the adaptations that you use to make a diagnosis of any disorder in a person who has intellectual and developmental disabilities. This is what it looks like. I do have a chapter I wrote in here. I don't get any money from that, so I also feel like this is not a disclosure. But if you were interested in working with folks with IDD, this would be a very useful tool for you. So I'm going to go through some of the adaptations in diagnosing people with psychotic disorders. I'm also going to talk about the common presentations for psychotic disorders in folks with IDD. And then we're also going to discuss the treatment of psychotic disorders and the necessary monitoring related to medication use. And if you take away anything from today, I hope it's that psychotic disorders in folks with IDD essentially look the same as psychotic disorders in folks without IDD. So that's like, that's the too long didn't read, or the bottom line up front. They look very similar. There are some specific things that we'll go over that can complicate diagnosis, but I think overall, it's pretty similar. And if you feel good about recognizing schizophrenia, schizoaffective disorder, bipolar disorder, psychotic symptoms, then I think that you can do that also in people who have IDD. I believe in you. Okay, so this is the part where I warn you that we are gonna do some active participation, that like the pop quizzes will happen. This is your little red alert. So hopefully we will get the like chat figured out. I'm still not seeing anything. Anyway, we'll figure it out.
Real quick, you should have access now. If you look at the little the box icon with the arrow on the header that says questions, should be able to pop that out.
Oh, I see a hello. Thank you, Amber. Look at all these folks. I love it. Okay, got it. I was looking in chat. Silly me. Oh my gosh, look at all you lovely people who replied. Thank you so much. Now, do we know if anybody else can see this, or is it just us, me and you, Megan? Okay, so I think it's just us. So what I'll do is I'll ask you, and then I'll keep an eye on the chat. Yeah, somebody says, thank you very much, Sarah, who says, who says that you all can usually, you can only see yours. So what I'll do is I'll keep an eye on the chat. So just send it out there anyway, even though it's not something that you can see. I can see it. So we'll do it like that. All right, so let's first, that was your warning, great. And then let's talk about stigma busting. A lot of, if like, we all know, right? We work with people who have severe persisting mental illness, and that carries a lot of stigma. We also get stigma by working with folks who have mental illness. There's also a stigma of intellectual and developmental disabilities. So that kind of, it can be doubly stigmatizing. So I just want to first start with some stigma busting. The terms that are really used pejoratively that I actually won't say out loud because they're too hurtful to a lot of people who struggle with mental illness. But just like this implication that people with schizophrenia or schizoaffective disorder are more dangerous than like everybody else. But we know that people with schizophrenia are no more likely than people without schizophrenia to commit a violent crime. It's about the same as the national average. Those rates do go up if there are also substance use disorders at play, but that's also true for individuals with substance use disorders, that they might be at a higher rate of violence. I think we all know that people with mental illness are more likely to be the victim of a crime than to commit a violent crime. All right, so in working with folks who have IDD and schizophrenia. So there was a meta-analysis in 2020 that found that the prevalence of schizophrenia is 4.8. Now the population at large, so people, all people, is thought to be 1%. So that's a 4 or 5 times higher prevalence. And the CME question that you'll do maybe like after says 400%. And sometimes these number things trip me up, but 4 times more is the same as 400%. I don't mean to trick you with like 7th grade math questions like that. I'm not trying to be tricky. But yeah, so I think that talks about how either people with IDD might be more vulnerable to schizophrenia. There might be a genetic component that predisposes you to have schizophrenia along with a developmental disability, just because it seems to happen more. There's also some concern that it might be an overdiagnosis or a misdiagnosis. We just need more information. And as I talked about last week too, folks who have intellectual and developmental disabilities are very often excluded from studies, so we just don't have a lot of very good information on that. Okay. So let's talk about the DSM-5 criteria versus our DMID2 adaptations. So DSM-5, and I'm pretty sure DSM-5-TR all says that you have to have 2 or more of the following: delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms. So the DMID2 doesn't really make any changes from that. You still need those. Criteria to meet diagnosis for schizophrenia, but the DMID2 does encourage us to remember that folks with IDD might have more self-talk, which is common and not necessarily interpreted as an expression of a psychotic disorder. So that's like the one thing that they really want you to remember. The other thing is that we are looking at a change from baseline. So if somebody has always been a certain way, like since they were a kid, that's less likely to be schizophrenia, and it's more likely to be part of their intellectual or developmental disability. Okay, so this is my slide where I'm sure you all know this, but let's just go over it just to make sure we're all on the same page. So a delusion is a fixed false belief. Some examples are that the government spy satellites are watching me. Now that also might be true. I don't know. But like we would talk to the individual and we would determine like, well, do you like, I don't know, is there a reason that the spy satellites would be watching you? And like, do you maybe work for another country? Are you a CIA agent? Are you a terrorist or something? So like that wouldn't be a delusion if it's true. However, for most of us, I don't think that the government spy satellites are watching us personally. And very often, if you're curious about if it's a delusion or not, if you can ask the reason behind it, that might give you some clues. Another popular one is that, I'm married to, in this case, Selena Gomez, who did a fantastic job in Only Murders in the Building. If you haven't seen it, wonderful, wonderful show. Those kinds of delusions, like married to a famous person or a famous person is in love with me, those kinds of things. Somatic delusions can include things like my intestines have been stolen by space aliens and they probe me at night. And then another one is the people in my apartment above me are controlled by Russia and they move in the exact same steps as me. And then people watching me for nefarious reasons. Those are just some examples. I think if we've ever talked to somebody who has schizophrenia, they'll usually share those with you if you have a good enough relationship, like the things that they tend to worry about. Okay. And then let's talk about what are not delusions. So these are not. So if you have a great imagination, that's not a delusion. Magical thinking, which is more common in kids. The typical textbook example of magical thinking is a child whose parents got divorced and the child thinks that it's their fault, that something that they did caused the divorce. That kind of idea that a person has that kind of power over people, that's a normal developmental stage, and it's called magical thinking. That's not a delusion, that's just like a poor kid trying to make sense of the world. And it's easier to think that it's your fault, as opposed to your parents are fallible, imperfect human beings just doing the best they can. So that can stick around developmentally for people who have developmental disorders or intellectual disability. And so that's just something important to remember. So that kind of thing, usually you can sort out from a delusion. And then just like somebody having a fantasy life, like I'm a sheriff or I'm a firefighter, I'm a superhero, that's also not a delusion. That's just kind of wishful thinking, right? Like wouldn't life be great if I were a firefighter or a superhero? Wouldn't it be great if I could protect other people like people protect me? And I like an imaginary friend, also not real worried about imaginary friend type stuff. In an adult who has an imaginary friend, it's very often pretty similar as like a kid who has one. an adult with IDD might say, oh, Timmy made me do it. Oh, or Timmy drank the last of the Mountain Dew. It wasn't me. Like those kinds of things are pretty common if somebody has like an imaginary friend. And then the other thing is aggression isn't a delusion. So if somebody gets mad and like breaks something, or like, I don't know, like breaks something, or like hits a wall or punches a door, that's not delusions either. Now there could be, but it's important for us to look at it to see. Okay, and then hallucinations. So hallucinations can sound like, and the reason I chose this picture is this guy obviously hears these folks like talking about him or like whispering about him. So a hallucination is hearing something or seeing something. Usually it's those two, when there isn't anything going on. So like hearing a whisper when there's nobody else around, or hearing people talk to you or talk about you when there is nobody else around. So if there is talking coming from speakers or the TV, like when the TV's off or when the sound is off, those can also be hallucinations. And then the kind of quintessential, I think it's called Schneiderian first rank criteria, is two voices commenting on the individual, which is like what this picture is. But in this case, it would be two schizophrenia voices talking about you, which sounds terrible. It's so mean. And so we elicit it like that. These usually people like hear something from outside. So it sounds like it's coming from outside their head. This is also true for folks with IDD. So just like people with schizophrenia experience with schizophrenia without IDD experience hallucinations in this way, so do people with IDD and schizophrenia. It's the same kind of thing. And so you'll know, like when you've talked to somebody with schizophrenia, they'll hear something and they'll look like look around and try to see who it is. That's also true for people with intellectual and developmental disabilities. Or they'll know like, oh yeah, they're talking to me right now and they're saying this, but I ignore them. So all of those things are still true for folks with IDD. Oh my gosh, what isn't a hallucination? Oh, I'm so glad you asked. Let's see. Oh my gosh. So this is like, I can't believe my supervisor said that to me. If you were here last week, we also went over this. I just can't stop talking about this. It's so important. People are brought into my office like pretty commonly for like, oh, you know, he's talking to himself or she's talking to herself. And I'm like, well, what are they talking about? And then it'll be like, well, they'll go back in their room and they'll just be kind of like rehashing an old conversation. But like we all do that. Some of us do it in our heads, and then some of us do it out loud. Oh, I can't believe my supervisor said that to me. Who does he think he is talking to me like that? Doesn't he know? Like, I just can't believe nobody. That kind of thing is self-talk, and it's not a hallucination. And then, as I said last week, this is also us when we think of that perfect comeback in the shower 3 days later after somebody said something to us. So when we have enough like emotional upwelling to be like, oh, I should have said that. Also not a hallucination. And if you live in like a supervised or like a congregate home setting, there might just be more people to notice that you do these things. Like people might notice and say something to your psychiatrist. And then hearing your own voice or that of your family members, that tends to be, this first one, like the you're worthless, that tends to be more trauma, like, or trauma related. People who have had a bad time, like those intrusive thoughts can just kind of echo around in there, and those kind of re-experiencing PTSD symptoms can just kind of be rattling around in your brain. And then sometimes it can be very helpful things like people saying supportive things. One of the people I was talking to, I was like, well, what are these, like, what do you hear? And they explained to me this experience of like, you know, a deceased family member saying like, I believe in you, I love you, you can do this. So like really supportive. I am not going to treat that. That's wonderful. Let's like encourage, let's encourage that kind of like positive self-talk. Oh yeah, and somebody in the chat says, yeah, that they agree that we spend a lot of time and we all have these self-talk moments, and that like explaining it to others kind of makes you sound a little bit out there, but it's such a human experience that I don't think we talk about enough, and that just even destigmatizing normal weirdness that we all have is just really important. And it's funny, we all do this, we're just sometimes not always aware of it. And again, aggression is not hallucination. So I want to talk about aggression and we'll get there, but that's not a symptom of schizophrenia. I should say, aggression is not a diagnostic criteria for schizophrenia. With some caveats. And then traumatic re-experiencing, I talked a little bit about this with the you're worthless. It's just really important. And this can be really tricky to pick apart from schizophrenia. What is just a person's terrible trauma history that they are re-experiencing so kind of completely that it looks like a hallucination? So that's just something that you would get on just by kind of asking somebody's history, asking about the experience of the hallucinations or whatever unusual thing is going on for them. Okay, so the other symptoms are disorganized speech. I cannot do a good impression of this. It's really difficult, but it's where the words kind of stop making sense with each other. They kind of lose their meaning, or they're all just kind of jumbled up. Disorganized behavior also. So that's like just doing things that don't make any sense, like baptizing somebody in the water fountain on the psychiatric unit, or just like doing things that don't make sense. And then negative symptoms are often confused with the side effects of medications. So these are apathy, not being motivated, little interest in social activities, like that social isolation goes along with schizophrenia and can be confused for the side effects of medications. And then for a diagnosis of schizophrenia, it has to persist for 6 months. And then it can't be something else. Like it can't be like the side effects of a medication that you started, or it can't be that you had a UTI and were hallucinating. That's something different. Oh, here's our first case. Okay, get your keyboards ready because I'm going to ask you some questions. Okay, so Mr. A is brought to see a psychiatrist because of aggression, which we all remember is not a diagnostic criteria for schizophrenia. So glad you remember that. His home manager says that he just started having trouble at work. He's been more irritable, he's been lashing out verbally, and he's been talking to himself in his room. What do we want to know? Okay, I'm reading the chat. What do we want to know about Mr. A? What more do we want to know about him? Yeah, what's he talking about? Is he sleeping? What happened at work? Is this a change in behavior? What is lashing out? What does that mean? Did he just like sass somebody? What does he like to do at work? Did anything change? Oh, any medical issues? Very good, love that one. Is the job stressing him out? Good, all great questions. Yes, oh my gosh, we do want to know about health problems. Does he have any medication changes? Work stressors? This is so good. Yes, wow, I'm so glad you all caught this. Yeah, so then when you actually talk to Mr. A, it turns out his new supervisor is often in a hurry and rushes him. So it's kind of like a very stressful situation. It's spilled over a little bit into his home, but it sounds like most of the problem is happening at work. Yeah, so the clues that is not a psychotic disorder is that it pretty much only happens at work, like the lashing out and irritability. There's a little bit of self-talk at home, but I think all of us do that when we've had a bad day at work. We like come home and we're like, oh, get a load of this. And then that was a great example of self-talk and not necessarily hallucinations. And there weren't any other psychotic symptoms that we could like figure out. So there weren't any delusions. He didn't think, oh, he's out to get me for these reasons. And you can't make a diagnosis of schizophrenia if there is a better explanation, and having a hard time at work is a better explanation for Mr. A's symptoms than schizophrenia. Okay, let me see if I missed anything over here. Yeah, so yes, absolutely, we would want to know about sleep pattern, and we would just want to know what else is going on. Like what else is going on? Sleep problems, medication changes, changes in medical health. All of those things are absolutely important. Okay, so let's talk a little bit about schizoaffective disorder. Yes, I recognize that this is a catch-all oh no, hang on. Here, let me see, I gotta back it up. Yes, this is a catch-all diagnosis very often for people who have some mood disorder symptoms, meaning depression or mania, and psychotic disorder symptoms. But the actual book definition is uninterrupted period of illness during which there is a major mood episode concurrent with, and then is the quiz. And then I'm gonna ask you with, so this is the diagnosis of schizoaffective disorder. So those mood things, and then what were those 5 symptoms, those 5 main symptoms we discussed with schizophrenia? Hallucinations, great. Anna, good job. Okay. And, oh, delusions, great job, Janet. And Alpha, great, love it. Okay, excellent. Disorganized behavior, excellent. Sylvia got it. Negative symptoms, great, Janet. You were like killing it. This is great. Disorganized speech, paranoia. So delusions, I think we got them all. That's great. You all are doing so great. Love it. Love it. Okay, hallucinations, delusions, good. Disorganized speech, disorganized behavior, and then those negative symptoms. Great. Oh, you guys are killing it. And, oh look, I even put a little GIF or GIF in here to say you all are doing a great job. So it's those symptoms in addition to a manic episode or depressive episode, the delusions and hallucinations for 2 or more weeks in the absence of those mood symptoms. So it's kind of like a hybrid of schizophrenia and bipolar disorder. Part of any diagnosis in the DSM is usually that it cannot be anything else. So this can't be caused by methamphetamines. It can't be caused by steroids. And yes, it does tend to function as a catch-all diagnosis, but people have this. And I think more and more we're learning that psychotic disorders like schizophrenia, like schizoaffective disorder, and like bipolar disorders tend to be more on a spectrum than these very like kind of discrete individual diagnoses. All right, oh my gosh, what is this delightful little can of sardines? Sorry to everybody who hates sardines. I think they're delicious. Anyway, so here's our next case. So Miss B was brought to her local emergency department because she had been increasingly erratic. Her mom reported that she had been different for a little bit now and that she seemed to have lost interest in her friends. Miss B started to lose weight, and after she thought her food tasted off. She slowly stopped eating most foods that were not prepackaged. Miss B would ask her if a peer, so Miss B would ask her mom, like, hey mom, has so-and-so been by? Have they been in the kitchen? Have they been messing with my food? Okay, so what further information do we want to know? I'm gonna go ahead and say that no, that friend hadn't, or that peer from work had not been by. So yeah, when did this start? Is this recent? Was it sudden? That's a great, how old is the patient? I'll go ahead and say that she is 20 years old. And then are there medical issues? Somebody, Elizabeth, thank you so much, says urinary tract infection. Any changes in medications? Did something happen to her between her and that peer? Great, like did something happen at work that would make her reasonably suspect that that peer would do something? right. Did something happen to the food? And in this day and age of COVID, I would also say, like, does she have COVID and like she's lost her sense of taste and smell, and that's why it's kind of off. And then any recent traumas that we would want to know about. Absolutely. Right. So did she get started on any medications? Did she get started on steroids? I'm looking at you, Kepra. Kepra very often causes psychiatric side effects in treating epilepsy, and patients who have intellectual and developmental disabilities, like the rates of epilepsy in folks with IDD, I think it's like 30 or 40%. So it's significantly higher than folks who have schizophrenia without IDD. So that's always something that we're kind of battling. Are the seizure medicines that somebody's on causing side effects? Are they causing mania, or are they causing psychotic symptoms? So that's always important to keep an eye on too. So, Janet, Kepra is often the culprit. I agree. I agree. Oh, it's always the Kepra. It's also, Kepra is a great medication for seizure control. So we're very often kind of battling this, like, you know, what is more important? A person who is really struggling with anger outbursts because of the Kepra, or that seizure control that's so important. So very often I talk to the neurologist and say, is there anything else we can use? Anything, please. Yeah, and so we want to make sure that Miss B is screened for other medical conditions before we assume that this is schizophrenia. Yeah, I think you all mentioned trauma, depression. Is she depressed and that's why she's not eating? Good. So we want to know all of those things. And I would imagine that story is pretty consistent with schizophrenia. And there have been some studies about diagnostic overshadowing in folks who have intellectual and developmental disabilities, that sometimes, like, I think from this question, or from this case example, I think it's pretty clear to us that this person, yeah, probably has schizophrenia or something pretty serious going on. But these studies that look at diagnostic overshadowing demonstrate that very often people miss this pretty clear diagnosis if somebody has something like intellectual or developmental disability, where these symptoms will be chalked up to having a disability rather than having a psychotic disorder. So that's just something to be aware of next time you are with somebody who has IDD and is having psychotic symptoms, that it looks pretty similar to people who don't have IDD. So just a reminder, diagnostic overshadowing is when we attribute symptoms to having an intellectual disability rather than a mental illness. It's just important for us to remember. Okay. So we did this. Here, I'll click through this. So just to kind of round out the group, brief psychotic disorders less than a month, schizophreniform disorders between 1 and 6 months. There aren't really any pertinent adaptations for us to talk about in the diagnosis of somebody who has a psychotic disorder and IDD here. Okay, and I just couldn't pass up the opportunity to talk about delusional disorder. Delusional disorder is, you know, fairly rare in the general population. Criterion A, which is the hallucinations and delusions for schizophrenia, is not met. So a person with delusional disorder does not have hallucinations or delusions, or that disorganized speech or behavior, or those persistent negative symptoms. But they do have one belief that is a fixed false belief, a delusion like we've talked about, but their functioning is not markedly impaired and their behavior is not obviously odd or bizarre. So the two examples of delusional disorder that I chose that actually have a fairly big following, especially since the internet has allowed people to connect with each other, so the first one is a little example of Morgellons disease. I think is what the group of people who kind of share this idea. And Morgellons is where you believe that you are infested with like microscopic parasites, and then you kind of like have these like little fibers that like you pull off your skin. the psychiatry name for it is delusional parasitosis, which I feel is like a kind of pejorative, and very often like, how are, you know, like I had to be treated for scabies once, and like you never know, you never see them. There was an outbreak and everybody had to get empirically treated. Please do not worry. my like personal health and or hygiene. But yeah, it's like one of those things like where if you have it, like sometimes you don't know. But people with delusional parasitosis or Morgellons disease could benefit from having some psychiatric treatment. It is hard to treat. And then my second picture that I have here is chemtrails, which, you know, is the idea that these planes going across the sky are like seeding the atmosphere with some kind of like, I think it's usually like a mind control substance. So if you have these kind of beliefs and they don't impact your kind of daily functioning, you might classify for a diagnosis of delusional disorder. And yeah, usually we just want people to have kind of like supportive treatment and just make sure that we increase functioning as possible. So my experience, and I have not been able to find anything to write this up or to support this in the scientific literature, but I see quite a bit of delusional disorder with my folks with IDD. It's usually the erotomanic type, where a person feels like they are married to or with a famous person. So my example of Selena Gomez, I don't have anybody I'm seeing who has that particular thing, but it's not uncommon for folks that I see to have these very fixed false beliefs of being married to a famous musician or a famous wrestler from WWE. Like those kinds of things seem to be more common in folks with IDD. But again, yes, I have not been able to find the literature on that. Oh, and then somebody says, my client does that with a royal family member. Yeah, it's just really interesting. And I try not to be like shaming. I just try to be generally interested. And we can sometimes do a little bit of an antipsychotic to see if that helps. But usually it's just a lot of like support and just increasing functioning and socializing. That was a total tangent. I just love to talk about it. I just find it so interesting. And especially with the internet now, people just connect with these kind of like shared delusional beliefs. And so I think it's great for support. I think it sometimes is not so great because sometimes it can get in the way of kind of re-engaging with real world. Okay, and then schizotypal personality disorder. Some people say schizotypal. You do you. I think you can say it both ways. So it's and actually I don't know which way I'm going to say it now, but schizotypal personality disorder is now officially considered to be one of the schizophrenia disorders. Now it's also more fully described in personality disorders, but I wanted to include it here to be complete. So it's a pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for closer relationships, and as well as cognitive or perceptual distortions and eccentricities of behavior. I included this picture because like I just love it. Like we've got this very eccentric looking person. We've got some dead flowers. We've got some old lace. So just like as a visual, I don't think this model has it. It's also not my place to diagnose them. But I also think that it's just interesting. So people with this disorder are more likely to have people with schizophrenia in their families. I think the reverse is true. So people who have schizophrenia are more likely to have family members with schizotypal personality disorder. So there does seem to be some significant genetic component, some preload that maybe somebody with schizotypal personality disorder didn't kind of tip over into schizophrenia during their developmental during the phase of life where schizophrenia typically happens, which is between 15 and 25 is the usual range. You can get it later, but it's usually around that kind of young adult age. It's especially heartbreaking. Well, I think this is also a good point to say. So families of people who have intellectual and developmental disability have come to terms or have embraced their child who has intellectual and developmental disability. And just as with any diagnosis of schizophrenia, it can be really heartbreaking. You've already had a kid who has special needs, and then you have an adult child who also has schizophrenia. There are a lot of really great supports out there. So usually your county board of DD will probably be able to connect you either with your local NAMI group, who's a really good support for parents and family members. And I just think that that's really, really important to talk about. Okay, other disorders that coexist with schizophrenia, we have OCD, we have mood disorders, trauma-related disorders, substance use disorders, and other disorders. I also want to put nicotine, like what are the studies? It's something like 80 or 90%, if anybody remembers off the top of their head better than me, 80 or 90% of people with schizophrenia smoke. And it's the idea being that the actual cigarettes and the nicotine reduce the symptoms of schizophrenia. It also impairs, it messes with your medication metabolism, so just be aware of that. So if you suddenly stop smoking, it can make your medication levels change. But please stop smoking. I think everybody knows that. Oh, are we ready for a pop quiz? Okay. So are people with schizophrenia more or less likely to commit violent crimes than people without schizophrenia? Let's see. Ooh, we're not ready for a pop quiz. Oh, no difference. Love it. Yes, same, good. Oh, thank you so much. Look at all you, love it. Okay, haha, no difference. It wasn't a trick. You all knew the answer. Excellent. Now, is talking to yourself in a room without, about having a hard day a symptom of schizophrenia? Love it. No, absolutely. You all are doing wonderful. Really, that's all I want you to take away from today is that people with IDD and schizophrenia look like people with schizophrenia. And just talking to yourself about a hard day is not schizophrenia. Yeah, that's okay. Now, what if people can see me through my closed curtains and are tracking my movements? Is that schizophrenia? Oh no, I have to scroll really far down because we have, oh no. Yeah, so that's a maybe see a psychiatrist there. So if somebody can see you through your closed curtains and are tracking your movements, so that's maybe, yeah, that's maybe see a psychiatrist about that. What if I have to tap things 7 times in a clockwise pattern while blinking my right eye? Is that schizophrenia? Oh no, why does it keep clicking my answers? So somebody says, could be. Yeah, absolutely, it could be. Yes, then everybody says OCD, maybe OCD. Yeah, so that one also is maybe see a psychiatrist for OCD. Now, as we talked about, people with schizophrenia meet criteria for OCD 50% of the time. So there's a huge kind of co-occurrence rate there. But also just go ahead, see a psychiatrist about that. Also, I don't mean to be flippant about that. I understand how difficult it is to get in to see a psychiatrist. I get it, we're training more psychiatrists who are good at treating severe persisting mental illness here at Wright State University, and who are great at working with people who have IDD and severe persisting mental illness. Okay, now let's talk through the treatments real quick. So we want a good evaluation. We want a good, thorough medical workup. And to remember that a psychiatric diagnosis is always one of exclusion. So if something else is going on, if somebody's got a thyroid problem, they've got a UTI, we cannot make a diagnosis of, gosh, anything really other than, health-related psychiatric symptoms. But yes, usually pills are part of the treatment equation, especially for schizophrenia, schizoaffective disorder, and bipolar disorder. So the APA guidelines are actually very kind and very thoughtful. An antipsychotic medication with monitoring for effectiveness and side effects, continuation of medication for those whose symptoms have improved. So maybe consider taking your medicine. And then right up here, right up front, they remind us clozapine for patients with treatment-resistant schizophrenia or those with substantial risk of suicide or suicide attempts. Remember that people with schizophrenia have a really high rate of suicide. And then the other reminder is for long-acting injectable antipsychotics for those who would prefer them. So But wait, there's more. We also need coordinated specialty care for programs of patients experiencing a first episode of psychosis, and CBT, therapy for psychosis, psychoeducation, and supportive employment services. Again, this is sometimes in some areas like just wishful thinking, but if you can get these things, absolutely wonderful. That's great. So these are the guidelines that we should be aiming for. Okay, so let's talk with Miss C. Miss C was brought in, Mr. C was brought in by his sister because Mr. C had told his home manager that the ghosts were telling them that he was a bad person. Mr. C's sister said that she had seen him look like he was hearing somebody talk to him, but nobody else was around. She said that he was also doing weird motions with his hands before entering a room. He said angels were warning him to be careful and would sometimes talk about him. Okay, so Mr. C was evaluated for medical illness like UTI, MS, lupus, seizures, but was found to be relatively healthy. His psychiatrist wanted to start a medication. What should they choose? Oh no, this is supposed to click ahead. But yeah, they're supposed to choose the medication with the best side effect profile for Mr. C that they also think that he would want to take. And then I've already reminded us about this, but just remember that the APA recommends specialty care for somebody with a first episode of psychosis. I know that TCN has a good first episode psychosis program. TCN's here in Dayton. I think we might be all, sorry, it's in Xenia. We might be all over the state. But I think that if you Google first episode psychosis, and I would imagine that there is something in your area. I know NeoMed has a program too that's very good. Oh, also, sorry if I didn't shout out your first episode psychosis program. If you wanted to put it in the chat, I will say that out loud too, in case you need to drum up some more business. So lookalikes, oh, okay. The first, all caps, program has multiple programs across the state. Yeah, absolutely. So it sounds like FIRST is through, oh, that's the NeoMed program. Okay, thank you so much for, for clarifying, you all. So other lookalikes are anti-NMDA receptor encephalitis, which is a type of brain inflammation that can first look like a viral illness with fever, headaches, and fatigue, and then it's followed by delusions and hallucinations. We do not treat that like schizophrenia. We treat that as anti-NMDA receptor encephalitis. And it's usually on the medical unit of the hospital, and I think it's with IgG. Please don't take my word on that. If you are treating somebody who has anti-NMDA receptor encephalitis, go ahead and follow those guidelines. And then remember that stimulant-induced psychosis can look like schizophrenia. It typically follows an overdose or a binge of stimulants. And then remember, cannabis is very popular right now, but it can cause paranoia and has been linked to a significant increased risk of developing schizophrenia. The high potency cannabis is not like your mom or grandma's weed. It's not the same. It's like really pretty potent and can, if in a vulnerable person, can trigger schizophrenia. And it seems to be in a dose-related response. So like the more you smoke, the kind of more dangerous it is for you to develop schizophrenia. All right, and then monitoring. These are important things to remember. Because our medications can cause weight gain, dyslipidemia, it's important for us to monitor these things. So hemoglobin A1C, that's your long-term blood sugar, your cholesterol, weight, BMI. Yes, I know BMI is not great, but it's one of the things that we can use to monitor weight. Orthostatic changes. Orthostatic means, if you're not familiar, like is when like you go from laying down to standing up. Like if you get like kind of dizzy, yes, you might be dehydrated, but your medication that you take might be impacting how your body, how quickly it can respond from you going to from laying down to sitting up to standing up to walking. And then sometimes there are guidelines that recommend for a baseline EKG because of impact of cardiac electrical communication in your heart, and then watching for tardive dyskinesia through the abnormal involuntary movement scale. Okay, side effects are really important. there's so many side effects, and antipsychotic medications are a lifesaver, absolutely, and they carry a significant side effect profile usually. The most bothersome ones are things like dystonia, so that's why I chose this picture. She's like holding her neck. It doesn't have to be your neck. That's usually like the typical, like the textbook example is like somebody's neck gets twisted over like torticollis. But like you can get like just a weird like bicep muscle can get constricted, and that can be very painful. Akathisia is like a restlessness where you feel like you have to move, where you can't rest, you can't sit. The one I hear about most often is sedation. People just feel pretty tired and out of it. Weight gain. Constipation is can be really dangerous in folks with IDD. GI problems like constipation are more likely in folks who have IDD anyway, and then you add a medication that further constipates somebody can be very dangerous. Ones that are kind of annoying but also can be problematic are dry mouth. You have a higher risk for cavities. We talked about the cholesterol, tardive dyskinesia. NMS is the fatal. It can be fatal for folks. So that's a very important one to watch for. And then sexual dysfunction, tremor, myocarditis, and agranulocytosis can also, myocarditis and agranulocytosis, which meaning like you don't have like enough white blood cells. Those can be fatal too. Somebody says, can somebody who uses cannabis have a period of time to show symptoms of schizophrenia, but those symptoms subside? Yeah, so I think this is present in popular culture where like somebody will smoke weed and then, nobody smokes weed anymore. Everybody vapes. Then they'll like get paranoid and they're like, oh, do you hear that? Like the cops are out there, and they'll like be looking through the windows. So yeah, and that can kind of go away. That's not schizophrenia. I think that's like a side effect of cannabis, or I should say of THC. But yeah, I think that's not schizophrenia, but I think those effects of THC can increase your risk for developing like actual schizophrenia. Okay. Some clinical pearls. Remember to monitor efficacy. So if we start an antipsychotic for somebody, let's make sure it's actually doing something useful. If it's not doing anything useful, maybe we should stop it. And then side effects in folks with IDD can be hidden. I mean, if you think about it, if you just got some weird muscle that's like pinched up in your back, like you might not be able to say that. If you have limited like expressive language, it might be more difficult for you to say. And often a lot of us struggle with like putting into words what our body is doing. That can be really tricky to kind of think through it and then say it out loud in words. And then my next point is that non-compliance can be less of an issue, but and that's a typo. Non-compliance can be less of an issue, which can be more of a problem because you have somebody there. Usually, if you live in a group home and you have IDD, you have somebody there like giving you medication. So it's harder to forget. It's also kind of interpersonally harder to refuse. If I don't want to take my medicine, I just leave it in the bottle. If somebody who has MedPass with their favorite home manager hands them a medication, it can be like emotionally much harder to refuse. I should say decline. That's why it's in air quotes. Oh, so somebody says, what are the suggestions for a client on so many medications and checking for efficacy? Yes, I feel like you were a plant in the audience. Thank you. Anna, I love this. That might be my very next slide. Okay, well, it's 2 slides from now. Psychotic symptoms I will answer that question, yes. Psychotic symptoms tend to look the same in folks with IDD as those without. I hope that's what you take away from today. And then remember to screen for trauma, which can very often look like psychotic symptoms. And I already lectured you about constipation, but please just be on the lookout for that. Oh my gosh, polypharmacy. This is Anna's question. So folks with IDD tend to have much higher rates of polypharmacy than the general population. So maybe look at, is the medication effective? And I think your question is like, how do we figure out? So we look at what is it supposed to be treating? Do they even have, do we believe that they have that diagnosis? If we're kind of suspicious that they might not have that diagnosis, what we do is a trial dosage reduction. So we very slowly take them off the medication and then see, like, do we see any return of symptoms? Are things sneaking back in? Are things getting kind of strange? So that's one of the ways that we can do it. And then sometimes if medications are causing significant side effects, then it might not be worth it. And this is a discussion that you have with your patient and with their guardian if they have one, and usually the other kind of caregivers or invested folks who are there supporting your patient. Are the side effects so bad that we would prefer to have psychotic symptoms? I think that's a reasonable thing in some cases. And I think that antipsychotic medications can be pretty uncomfortable to take if you're not on the right one for you, or just period. They can be uncomfortable or painful to take. And then we want to watch for side effects too. It's just so easy to have one more medication added to a very long medication list. Let's see, so I already talked to you about this. Let's see. Okay, let me see. We've got some questions in the chat. Let me see. I think let me just get through this one case and then I will absolutely do this. Okay, so Miss D presented in the clinic with her new home manager who's worried about how Miss D was talking about if their phone would ring and that people would come after them. And then Miss D wouldn't answer the phone and tried to stop the housemates from also answering. Miss D slept with the lights on and prefers to sleep on the couch in the living room. What do we want to know? Yes, yeah, so she's been, she hasn't been having any nightmares. She's just scared to go to sleep. So we would worry, like, is she having nightmares? General health is pretty good. There's no new medications. And then when we ask about social stressors, we find out that Misty has been spending her time at her sister's house who loves watching scary movies. And then since her mom passed away, her sister is more permissive with scary things. So those kinds of things also happen for folks who have IDD. I think it also happens for everybody. But like this is like an example of somebody who might come into my clinic, certainly around Halloween time when all the spooky, scary movies are. Okay, and I think, perfect, this is time. We got some time for questions. Excellent. Okay, so let me scroll back up. Good, we covered that. Because of the high rate of seizure disorders in our ID folks, it's always a good idea to have a thorough discussion on achieving that balance of treating seizures and treating the psychotic disorders. Absolutely, I agree, yes. And that sometimes VNS can be a good non-medical option for the seizures. Absolutely. Yeah, I think that's a great idea. Like that somehow we have to find that balance between so many seizure medicines, psychiatry medications, and like the balance of psychiatry symptoms and neurology symptoms. And then somebody says DNA testing for sensitivity of drugs, which would work best for this person's DNA? Okay, so this is a question that comes up pretty regularly. And we actually were able to give a talk at the NAD conference, the National NAD conference, which is a national association for people who have developmental disabilities and mental illness, about like the genetic testing. So what it looks at is how your body metabolizes the medications. So the gene testing does not tell you what medication will work best for you. I really hope that like one day we can get there, that we just do a blood test and we don't have to do like, well, let's try risperidone, let's try aripiprazole, let's try, so that we can just do a test and then we'll know the best medication for somebody. We're not there yet. Right now, what we do is we test to see if you are a fast or slow relatively metabolizer of a certain medication. But that there hasn't been a good linkage to improved outcomes with genetic testing. So I think that's a really interesting area of growth that will probably just really take off. Hopefully soon. It will make my job so much easier. Let's see. A lot of mental health disorders rely on a timeline of symptoms, but people with IDD sometimes aren't very good at indicating when something happened. Oh yeah, and then with staff turnover, it's really impossible. Yes, and then it's impossible to get someone admitted to an inpatient unit, and in rare circumstances, when they do get admitted, they are just turned around just and sent out just as quickly. How can we advocate for more help? I call call the hospital. I give them my cell phone. If I know, this is if sometimes like my patients will be in and out of the hospital before I even know. If I know, I give the emergency department a call. I say, hey, this is a person who has this psychotic disorder. They have these psychotic symptoms. Please, we just need some help. So I pull the heartstrings if I can, but very often an inpatient psychiatric unit can be a very distressing place for everybody. So that's like one of those tensions that it's really hard to work through right now. That it sometimes can feel impossible to get good psychiatric care for our patients with IDD. It's just really, it can be really frustrating. So I agree. Oh gosh, thank you so much. I think that's our time. The end. Here are my references. Oh no, where'd they go?
All right, just as a heads up for everybody needing CPD or CEU credits, you'll be receiving an email with a link to DODD My Learning site that's got a short survey for you to fill out, and you will receive your certificate through that.
Gosh, thank you all.